This is my 70th birthday. Almost all of my family and many of my friends expecting about 200 people tonight is wonderful. I never thought I'd reach 70 years old. I never thought I would survive 5 years of cancer. When I was diagnosed 5 years ago, it was pretty dire. I said, okay, the diagnosis has me living only a few more months, but I'm not ready to give up yet. I want to try some things. I want to experiment. I want to find a doctor who will experiment with me. I want to try things out. I can't just accept at face value my fate, that it be death in 8 months. I've worked hard at this. I've studied the disease and the treatments. I've interacted with some fantastic doctors who will share their insights into the disease and into what's happened lately. There have been many changes in the view of and treatment of lung cancer in the last 5-10 years. So I've been very active. I've had a huge support group. My family, of course, my close family, my kids, my wife, and many, many friends. So I've had quite a journey here. I want to share my treatment, how we monitor my disease with CT scans and PET scans, how I've interacted with my doctors and how I've interacted with science as it's moved forward.
Well, first of all, he's a very good friend. He's married to a very good friend, a woman who was a commissioner of mine when I was mayor. And I've watched Wells fight this disease. And he's done so, I think, in a very uncommon way, with a drive, a spirit, a motivation that not only has affected his own disease positively, but I think affected a number of other people positively as well.
I'd like to talk about the period 4 years ago when I was first diagnosed. It seems like a very long time now, very long time ago. We've been through so much, but it's good to recall the shock of those weeks. I had been working as a physicist for many years, and just before my diagnosis, I had been working on some projects that were involved with some product liability. I'd been working in England. I've been going back and forth to England, and it was rather tiring, and there were a lot of things going on in my life, and I was getting tired. I was losing weight.
Wells had lost about 15, 20 pounds. We had gone up to Yosemite with some friends, and he had tried to walk up some paths, and he just couldn't possibly do it.
And I didn't think much of it because I've always been a type A, really worked hard at things, and really was pretty intense.
I could tell Wells was not well, number one. I could tell for, say, 6 months before there was something wrong. And I kept asking him to get it checked out. And he kept getting a little more annoyed and a little weaker. And it was very frustrating because I didn't know how to get him to deal with it. You know, it's just really hard when you can see someone deteriorating. And anyway, I finally found the tool, and that was, I told him that he was behaving more like someone he didn't like, some one individual he didn't like, than the individual he liked. It made him understand that he was really being silly. Anyway, it got him to the doctor.
We had an x-ray, and they said, well, you better come back for a CT scan. I had a CT scan, well, you better come back for a needle biopsy. And then the news was dropped on me by, I must admit, a doctor who seemed at that point more like an undertaker than a doctor. And he said, you have stage 4 non-small cell lung cancer, and it doesn't look good. We all kind of looked at each other and really didn't know what to do.
My mother had died of lung cancer. 2 of my aunts had died of lung cancer, and my experience has not been very good with lung cancer. So I had a very fatalistic feeling from the very beginning because that was my experience and because of what I had seen in Wells in the last 6 months.
Wells, I remember the day you told me you had cancer. It was early April of 1998. You had just been reelected to the board of directors of the International Institute. And I called you up to transact some sort of ordinary conversation with an ordinary board member, and you said, "I'm not sure that's going to work. You know, I just found out I have lung cancer." And I was stunned.
It would be lying if I said that I wasn't a little bit scared, because you and I had started to get very close, and there were times when I was very afraid of losing you and losing our relationship.
And I said, "Lung cancer?" And you said, "Yeah, stage 4. I said, "What do you mean? You said, "Oh, that's the worst kind. They gave me 8 months."
Most of us don't think much about serious disease, don't think much about death in our normal life. We go on about our life, we know what's out there, we know what happens to other people, we know it's going to happen to us eventually, but we don't think we're quite ready, particularly if we're feeling good and we're working hard and we're leading a good life. Then all of a sudden you're told that things have changed. Your life has changed. You have a timetable now of 8 to 10 months, and that's what the statistics show. That's probably what's going to happen.
Today, lung cancer is one of the most devastating and serious problems facing us. It is, in fact, the leading killer with regard to cancer death. Our hope today is twofold. One, to be able to detect the disease early enough that we can intervene with treatments that today are effective. Most importantly, we must do the research to develop even better methods of detection and better methods of treatment for tomorrow.
Both my inclination and my wife Ann's was to cope with it, to take it in, to not to hide it from ourselves or from the children, but certainly not from ourselves, to either give up or to not do anything. We're both doers. We think we can solve problems, work on problems, so we immediately started to do things. I remember I called up that afternoon the company I was working for then and effectively resigned. I said, the priorities in my life have just changed.
Here he was, almost 65, decided to retire right away and really just plunge into dealing with this disease. So we were in the middle of remodeling this place in Glen Ellen and planning for his 65th birthday and all that stuff. So I just had to keep on track and then start supporting him in the best way I could.
The next week we started to interview doctors. We started to ask people about treatments. I got on the web and started to learn about what lung cancer was all about. We bought books, and we just started on the whole process.
Our current methods of detection, prevention, and treatment of lung cancer clearly need to be improved, and the best way to improve upon them is for us to do the research to understand lung cancer, to understand the mechanisms that give rise to the development of cancer in the lung, and also those mechanisms that cause the cancer to grow and to spread and take someone's life.
There's been an interesting transition, I think, over the last few years in that patients are much more engaged in the process, the decision-making process about treatments. And patients are also much more educated when they first come in to see the physician. It's not unusual at all to have patients come in now having done their own literature search, or perhaps even a search of the physician to see what his background is, what his special training is. Patients are more interested in clinical trials now, and that's good.
Wells has been extraordinarily proactive in his care, and that is very enlightening. I think it's a wonderful way to approach an illness.
My search for knowledge in the early days was to do research both on the web and in print. I went to libraries and I talked to people and I went to conferences that I could and so on. But the web was extremely valuable, particularly at the beginning, because there are many sites like this oncology.com site, which is now associated with ASCO, which is the American Society of Clinical Oncologists. And you can find it about all kinds of cancer, and you can click around and see what the treatments are, what the protocol is, what some of the standard treatments are, and gain a lot of knowledge. What I go to more now is some of the detailed ones to find out where drugs are in clinical trials, what the new drugs are, where the research is going from a technical point of view, because that's what interests me. I'm trying to think ahead now.
One of the most important initiatives in the prevention of lung cancer is to focus on the problem of tobacco and smoking. If we can eliminate tobacco and smoking, we can eliminate the most significant cause of lung cancer.
Well, one of the main frustrations is that lung cancer, for most patients, is a preventable disease. Even though we have advanced technology, we still have a extremely common leading cause of cancer death in the U.S., wherein we're still looking at a 15% 5-year survival rate for a very common disease. That's very frustrating.
Tobacco carcinogens is extremely potent and extremely potent damaging DNA.
The first question that anyone asks me if I say I have lung cancer, did you smoke? There's some interesting statistics there.
The risk of smoking, whether they're perceived as high or not, depends on who you are and how old you are. If you are a lifelong smoker, you have about a 50% chance, a 1 in 2 chance of dying from some smoking-related disease.
And if you never smoked in your life, you still have a reasonable chance of getting lung cancer. Because there are many other things in the atmosphere and in one's life, particularly those of us who live in urban America. We're exposed to many things that go in our lungs and can affect our lungs, can make those first genetic mutations which lead to lung cancer. But I did smoke. I smoked early. I started smoking. I started stealing cigarettes from my mom when I was probably 15 or 16, and I smoked till I was about 31.
And there are also other scientific studies that show that the earlier you start smoking, the more likely you are to be addicted and the harder it is to quit.
So kids like me who stole cigarettes from their parents and started smoking real young, they're in the most danger. It's why for smoking cessation programs, we really concentrate on the young.
Smoking cessation really is crucial. We know that smoking is the leading cause of preventable heart disease. That includes certainly cardiac disease as well as vascular disease like stroke. It's the leading cause of chronic obstructive pulmonary disease like emphysema and chronic bronchitis. It's a leading cause of lung cancer and a very significant cause of oral and laryngeal cancer and other cancers, pancreatic, bladder. So 1 out of every 3 cancers is caused by smoking, which is a phenomenal number if you really stop to think about it.
The other efforts that are underway are in the area of finding better methods of detection of lung cancer. We know that today our detection methods are inadequate. Too often we find lung cancer when it is already spread beyond the lung and for which treatment is very, very limited. If we could detect lung cancer early, at a time when our treatments could totally, completely eradicate it from the body, then we could help improve what is right now a uniformly fatal disease when it is spread to one that is able to be eradicated or cured.
Multiple studies have been initiated, many in Japan, and then a major study by Dr. Claudia Henschke at Cornell in New York City, showing that spiral chest CT scanning can detect lung cancer at a reasonable rate when comparing to other detection schema, and can also detect lung cancer in its earliest stages.
I'm here today at the hospital to get a CT scan. A CT is really a computerized X-ray. The X-ray source and the camera revolve around you in a donut. What that does is to give a rotating 360-degree view of the inside of your body, and that is all put together again by the computer to give you a real-time image of what's inside your body. At this point in my treatment, I have them every 3 or 4 months, and probably I'll be able to go to every 6 months soon because things seem to be very stable. Back when I was in more intensive treatment, chemo treatment, I'd have them regularly every 2 or 3 months, because at that point we were really trying to monitor size and number of tumors. At one point back in the second year or maybe third year after my operation, I had 19 tumors in my lungs, we discovered. So that year I had them every 2-3 months, and actually plotted how the number was reduced from 19 to 12 to 9 to 4. It showed a nice progression, a nice working of the chemo. Usually you have a contrast media. If it's for your lung, they will inject the contrast media through an IV in your arm. It's really quite simple. The whole procedure takes 10 minutes, something like that. And then they can immediately see the picture that the computer reconstructs, and they can see the masses inside your body. And the pictures are read by a radiologist who is skilled in that, and he or she can distinguish normal tissue from tumors.
The trial of comparing spiral CT to chest X-ray is available to current and former smokers. They can get further information about enrolling in this trial by contacting the National Cancer Institute's website.
And if you're in an area where you could potentially get access to being in that study, you could both get free screening as part of that study and help the medical community understand the issues involved.
I had a large tumor in my upper right lobe, but I guess the good news was that it was still in the lung. It hadn't involved the lung wall or the pleural wall, or it hadn't attached itself really to the wall. So that's why it was operable.
Currently, only about 1/3 of lung cancer patients that present with symptoms are eligible for surgery with an attempt at cure.
What we did was to reduce its size with chemo, and it did respond to chemo, and then it kind of separated even more so that they could go in and remove the major tumor. I've had a lobectomy where they removed the upper right lobe of this lung. That was because my major tumor, my large one, was in that lobe.
As I recall, he had a dominant tumor in his right lung that was, relatively large and technically challenging in its location, involving, as I recall, a sleeve resection to remove it successfully. But in addition, had a few other nodules scattered about.
And we had reduced it in size with chemo, and we felt that we could remove it and therefore reduce the tumor burden on my body. And that was, I think, a very good thing to do, even though it was a major operation, and it did result in a lot of micronodules, the 19 tumors afterwards, but then we could continue to work on those with chemo.
The point of the story was through, just the sort of state-of-the-art of thoracic surgery now, we're able to remove the entire tumor with a sleeve resection or whatever it was, I don't recall exactly, but he did great, and I remember vividly he was out of the hospital in 4 or 5 days and calling me from, the tennis court 3 weeks later.
Let's talk about chemotherapy for a minute. They are, in general, systemic drugs, meaning they affect the whole system, the whole body. They are thought of as poisons, but that's rather a negative approach.
It turns out that the first chemotherapy was a byproduct of World War I, when mustard gas was administered and people died of poisoning, and the doctors noticed that the white blood count went down while these people were dying. And after the war, they learned how to take mustard gas and give it as a drug called nitrogen mustard. And as you well know, that was the very first chemotherapy, but it's a poison. And they had to learn how to give the poison in the right amount so they wouldn't kill the patient, but could kill the white blood cells.
The reputation that chemo has is that some of the old chemotherapy regimens were quite severe, and in the sense that they had side effects which were severe. People would get very sick, nauseous, throw up, lose their hair, all kinds of things that really affect them. And fatigue is another one that's very pervasive. Some of the new chemotherapies are less toxic, meaning they have less side effects and therefore are tolerated better by the patient.
But as a result of all the research that's gone on over the past 20 or 30 years, and especially the Genome Project, we now know some specific molecular and chemical abnormalities that are present in cancer cells, and we've also identified certain genes like P53 and others that are abnormal in cancer cells. And the new approach to therapy is a designer drug that targets the abnormal chemical pathway or targets the abnormal gene and tries to fix it or eliminate it. It's like if your car isn't working, if the brakes aren't working, let's get a new pair of brakes. Let's not try to reconstruct the whole car. And if your gas pedal's stuck and you're going too fast, which happens in cancer, let's find a way to disengage that gas pedal.
Some of the other chemotherapies I had were better tolerated in terms of nausea and fatigue, but would affect my blood chemistry more. That's the other thing that oncologists really look for. Every time you go in for your chemo, they take a sample of blood, they test it. Thomas is an expert. He knows my blood so well. You probably can tell what my blood is just by looking at it. Oh, wow. If your platelets go too low, then you could bleed to death. If your red cells go too low, then you don't take in the oxygen and you have no energy. You're anemic. White cells go too low, then you don't have resistance to infection because your immune system is really compromised. So as I took chemotherapy, we monitored my blood, and for a while I kept a chart on that as well, and I plotted it out, and I would watch my white count drift down, and then we'd have to do something to try to get it back up, and my red counts would go down. And I never had to not have a chemo because of my blood, but I did have to have some supplements for white count and red counts at various times to bring them back up so that I could continue to take chemo.
Our dream would be that 10 years from now, and from your point of view, the sooner the better, we'd be able to take a tumor and not only say this is lung cancer, or this is alveolar cell lung cancer, but this lung cancer has these 5 gene abnormalities: EGF receptor, P53, AKT, I could name some genes. And furthermore, of those 5 gene abnormalities, these 2 or 3 are critical. And then we reach around on a shelf that has a label P53 treatment and EGF treatment and open the right drawers and give a tailored therapy to that patient. That's really targeted therapy that is based not on the fact that they have lung cancer, but it's based on the fact that their particular lung cancer has certain particular molecular or gene abnormalities in it. That's our dream. Well, back in 1980 at the University of California, San Diego, I was working in collaboration with a man named Gordon Sato. And the two of us knew at that time that there was a receptor called the EGF receptor on the surface of cancer cells, and that the cancer cells made a molecule called EGF, which was, when it was released by the cancer cell, bound to the receptor on the surface of the cell, sort of the way a lock and key works. So the cancer cell has a lock on its surface called the EGF receptor, and normally the key, the EGF, isn't available It only comes if you get a wound on your hand or something like that. The bloodstream brings EGF, and the key goes into the lock, into that receptor, and triggers the cell to proliferate. But the cancer cells have figured out a very interesting trick. They make their own EGF. So they can reach around and stick the EGF right into the EGF receptor, stick the key right into the lock, and auto-stimulate their own proliferation. That's a great target. So then we had to figure out how are we going to block that target. And we decided to do it by making a monoclonal antibody that would bind to the EGF receptor right near the keyhole, where the key would go in, and block the keyhole so that the lock could not be activated, the EGF couldn't get to the receptor. And we were able to do that. And interestingly enough, a lot of other folks and a lot of companies have decided that this is an exciting target and have built on this original work, and a half dozen other molecules from different drug companies, all with the same approach. And there are a few other antibodies also in trials. So I'd guess there's well over a half dozen clinical trial approaches using various ways of deactivating that particular target. But there are probably going to be a couple of hundred potential targets.
Well, angiogenesis is the process of blood vessel formation. And basically every part of the body requires oxygen in order to survive. If the brain doesn't get oxygen, it's dead within 4 minutes. A tumor cell is no different. If a tumor is to grow, it needs to have a supply of oxygen, and that requires blood vessels. So basically, what we're trying to do therapeutically is take a tumor and stop the blood vessels from forming. If you can't form blood vessels in a tumor, it's going to be limited in how big it can grow, not more than 1 millimeter, maybe a fraction of an inch. So basically, the goal of what we're doing is to take this process of angiogenesis, to block this process, and by blocking it, starving tumors of their nutrients and keeping them from growing. We've had some hints of activity. There's a drug called TNP-470. This is a drug that was one of the first angiogenesis inhibitors to go to the clinic, and we've now been able to show that in certain tumors, including lung cancers, there are hints that it produces more activity of the chemotherapy when it's given with the chemotherapy. So you actually have a way of enhancing the activity of chemotherapy by giving the angiogenesis inhibitor. And then I think what we all hope for in lung cancer is that people will live with chronic disease. And even if they're not cured, they'll live with the lung cancer. And I think an angiogenesis inhibitor offers that possibility.
Well, gene therapy is an attempt to restore normal gene function in the cancer cell, which has very deranged gene function. We know that cancer develops over a long period of time, and it develops because cells are exposed to agents which damage genes, damage the DNA within the nucleus of the cell. And that damage may be repaired. In fact, it is repaired in the vast majority of instances. Otherwise, we'd all have cancer at a very early age. But we know that in some cases it begins to accumulate, and that derangement then makes the cell more susceptible to further genetic damage. And so you have eventually a group of genes that are highly damaged in the cancer cell, and it causes that cell to grow in an uncontrolled way and to develop all the hallmarks we know that the cancer cell has. The concept behind gene therapy is to try to either restore the function of those damaged genes back into the cell so that the cell begins to function normally again, or to restore the function of genes that will recognize all that gene damage and cause the cell to self-destruct. It's what's called programmed cell death, or apoptosis. And it refers to what happens in a normal cell when a cell accumulates a lot of DNA damage. Normally, if our cells get exposed to damaging agents, this program will be triggered because of all the DNA damage that accumulates, and this self-destruction program will eliminate that cell before it becomes cancerous. This doesn't happen in the cancer cell. And so one of the major purposes of gene therapy is to try to insert normal copies of these damaged genes back into the cancer cell and have it trigger this programmed cell death.
It takes commitment of time and collaboration, because this is a situation where clinicians and basic scientists are going to have to work very tightly together, It takes a huge investment in informatics, because as we treat patients with different treatments and collect results and measure genes, we've got to pool data on a whole lot of patients and find the correlations. We can make hypotheses about which molecules to measure to predict whether a patient would respond to a treatment or not. But there's so many variables. To develop a drug today costs at a minimum $200 million, and it can go up to $500 million or more, and that's where the companies come in.
In the industry, there are a number of challenges. One is the clinical development aspect. If you have a drug that may be promising, typically it has to show some activity in terms of efficacy on cell lines in vitro, or in other words, in the test tube, we need to show that the drug can kill cancer cells. So the things to keep in mind with drugs are, number one, the safety, and number two, the efficacy. So you have to have some sense of that before you enter clinical trials for patients with cancer. So once the drug then is being considered for clinical trial, usually a company becomes involved. If the drug is found to be safe, then it goes on to a phase 2 trial, which involves a larger number of patients, and the goal there is to establish some means of efficacy. Does the drug work? If it does work, and that's promising, then the drug enters a phase 3 trial, which usually is the pivotal trial before a drug is approved by the FDA.
This is my study at Glen Ellen, and it's one we designed over 5 years ago before I was diagnosed, and it's become my haven, my treehouse. It is set up here in the oak trees. It's a story and a half up. It overlooks the vineyard and Sonoma Mountain, which, according to old Indian lore, Sonoma Mountain was a healing mountain for the Indians. So that's kind of appropriate. And I spend a lot of time here. I have spent a lot of time here the last 4 years. It's a very peaceful place. It has all my books and my family books around. During the early parts of my treatment, when I was on chemo, it was one of the things that I still wanted to do, even though those days, my down days, which are usually the third and fourth day after taking chemo, and that was usually on a Thursday I'd take chemo, and then so Saturday and Sunday I'd be really feeling down, no energy, depressed, feeling bad. I would still make it up here, and sometimes climbing the spiral staircase coming up was a chore. It was like climbing a mountain. Good boy. We're in the family room here in Glen Ellen, surrounded by some pictures of my family. I'm researching and writing a family history, my ancestors and all my relatives now. Having cancer and being faced with some ultimate choices about life make you think about family, among other things, and how precious it is and how very special a family can be. On my 65th birthday, it was held here in Glen Ellen just after I was diagnosed, and all the kids came here. I asked them to, and they all came from all over the country, all the grandkids, and for a week we were here in this house.
And it was really neat that everyone made it out there.
Very intense. We ate, we played tennis till late into the night, we talked. And by the end of the week, even though we love each other, we were totally exhausted and couldn't wait to get away. It was just so intense.
You know what I saw there was just a lot of effort in growing communication, and a lot of effort in really trying to be there not only for you, but I think in sort of reconnecting with each other.
Very early on, I told each of them about my disease and about my condition, and that I wanted their help, and that now was the time to deal with me, to talk with me, to ask me questions, whatever. I had a CT scan last week, and
I'm here to find out the results of that scan. I have been steady, meaning my disease has been has been stable for the last few months. And we do a CT scan every 3 or 4 months just to make sure that things are stable and that the tumors aren't growing or that nothing is happening. So that's what we're here to find out today. The best news from today would be no news, that nothing has happened, everything is stable, there's been no change since the last scan. That would be the best news. More troubling would be if something has changed. It would be very slight probably, and it would just make us wonder whether something was starting to happen. In that case, we would probably wait a few months and do another CT scan and just see if there's a trend here. One thing I've certainly noticed over the years, I've had, I think, 18 of these CT scans over the 4 years of my treatment, that any one scan is not that definitive. There's a little bit of ambiguity in the tests, so that, I mean, they're read by different radiologists, they're taken on different machines. So if you have a scan that's not exactly what you want, it could be that it's the scan itself or the report, and you should do it again in a few months and see if there are any trends. By looking at the several CT scans before your current one, a radiologist can compare, and he can say that's probably scar tissue, it's been there for the last 3 times, 4 times, it's not doing anything, it's probably not a tumor, it's probably just scar tissue. So in my report, they'll probably say something about, you know, my lungs are really scarred, there's lots of junk around, there's this and that, but it's all stable. And so that's good.
When Wells learned he had cancer, something changed. It's like every day, every person, every interaction became somehow more poignant, more real, more important.
This is sort of a typical weekend lunch period at Glen Ellen. This happens to be a holiday weekend, but people drop by, we spread out a lunch, we eat when we want to, we eat what we want to, and it's all very casual in the country.
Before the diagnosis, Wells hadn't talked about his family much or his grandchildren much, or the things that make him really joyful about being alive. And now he talks about that stuff all the time. It's wonderful for all of us.
This is grandson Chase, who's quite a tennis player and quite a climber. Yesterday, he went on a rock wall down at the fair, and he climbed up, right? And you beat your mommy to the top. It was awesome.
And it was high.
One of the things that we did to gather people around us, it was very important for me to get other people involved in my disease and in my treatments and in what was happening to me.
It's been very moving to see this hotshot physicist become kind of mushy about some stuff.
And one of the ways we did that was to ask friends and family if they wanted to send a piece of cloth, something they had worn next to them, close next to them, to send it in.
I got a note from Anne that you were going to do some kind of wonderful sculpture, and if every one of us on the list could come up with a piece of cloth or an old sock or something that would be sort of fluid and have a piece of our spirits in it, we should send it.
And we would cut and sew that into an art object of some kind. So we spent a number of weeks that first summer, again when I was in the midst of treatment and not feeling so good, taking these bits of cloth from around the world, sent with notes from people that knew me, and putting them into this sculpture, which now hangs on the wall up here in the study. And it's indicative to me of how if you open yourself to other people, there are communities out there. They could be your own family, they could be your close friends, or they could be friends who you've just known over the years. They will help you.
There's something that Wells started talking about after his diagnosis that he'd never talked about very much before, and that was ideas about community and what community is and what it can do for people. And I think it started with this huge electronic community of people who were being kept informed every step of the way of what was going on with the treatment and what was going on with the tumor and whether it was progressing or not, or whether a new chemo drug had been introduced or not. And all of a sudden, there's community everywhere.
Now, is this focused on lung cancer, or do we prostate cancer people get to, get some of the limelight?
This is Peter DeWeese, old friend, sort of brother. He's a prostate cancer survivor, and generally involved in all of this.
I learned a lot about how to deal with it by being with Wells when this horrible diagnosis and what sounded like a verdict came in May 4+ years ago, is that right?
Yeah.
So it was a real shocker to all of us, and then when Wells began organizing kind of a I don't know what we called it then. It was kind of we made up a name that wasn't really support group because that sounded a little too new agey for us. So with Wells, it's kind of, so it's a miracle. Look at, he's playing tennis. He's kind of old news now, but he's a living legend. He's a legend in his own prime. So I think he's probably the best model anyone could have for facing something which the odds were dead set against, and going head on and doing his best and using every resource he had, including his friends.
I can remember those first few meetings of the support group. You guys wanted to talk about everything else, and I said, no, I have needs. I want to use you. Yeah. I want to try some things out. I want to talk about some things. The group kind of...
On the one hand, you didn't want to seem to be directing the agenda. So you would say, wait a minute, we can talk about whatever you guys want to, but we said, no, wait a minute. You're the only guy here we know who's got an issue, has a diagnosis, and maybe we should kind of figure out what you'd like to talk about. Turned out we discovered that some of our number had ailments and health issues that nobody knew about because, guys don't talk about that stuff. It became commonplace to talk about cancer, and not at all forbidden, and in fact, we joked about it.
Yeah.
And then another friend of ours and I were diagnosed very close together as having prostate cancer. So we both had the same treatment, radical prostatectomy, and so we had more stuff to kid each other about and also to talk about and sympathize a little bit with.
You and Bob had been married how long?
Well, it would have been 9 years right now, so 8.5.
Mm-hmm.
And about 4 of those were spent half that time was spent with the cancer.
My recollection was that he didn't want to talk about it very much at the very beginning, and that we only found out kind of through the neighborhood rumor mill.
I think, well, one of the times that he met you and all the other fellows there, actually practically forced him, but he was also in pain from his leg at the time too, so he did go up, and he felt he was very glad he did go, and also he was very happy to talk to you because you knew so much about it.
Yes, I know. I can remember the last time I talked to him on the phone before he died. We were talking about a treatment, and he wanted to know what I was on and would it be possible, and he was still quite active. He wanted to be active in the whole thing. And of course, what Bob went through was what many of us who are in the game, meaning cancer patients, fear, and that is we never know when it's going to spread.
I think that had he known as much about the disease as you do at an earlier stage, he would have approached it differently. Mm-hmm. He would have gone for more opinions, but he was so convinced that it was not something that was going to spread because the fact he was told it wasn't going to spread. Yeah. So he was very trusting of that statement, and of course would have researched it, and I'm sure would have done very much what you did at a much earlier stage. Mm-hmm. Yeah.
Well, and the other part of that is to trust your doctors, of course, but not completely. Just like, we're all human. Doctors are human too, and that I know full well that my lung cancer is not cured and I'm not in remission,
and it still could spread anytime, anywhere. And I live with that.
Clearly, part of my treatment has been with conventional Western medicine, chemo and surgery and all that kind of thing. But as well, I've been quite interested and have taken part in various forms of complementary medicine, other modalities from other cultures.
Alternative treatment strategies are both areas for opportunity, but they are also areas for concern.
We need to define the efficacy and the safety of a number of these approaches. The safety, with rare exceptions, doesn't seem to be a huge issue, but the efficacy is.
These kinds of questions have to be addressed under very carefully controlled circumstances and in the context of a clinical trial where we can assess both the benefit and the risk of alternative strategies such as herbal medicine.
Ideally, it would be nice to marry both alternative approaches with conventional approaches.
Here at the Pine Street Clinic, I think primarily people associate us with information, because we'll see a person with cancer here, and primarily we're going to give information, we're going to make referrals, we're going to help design a treatment program. The position that we take here at Pine Street is the larger definition called integration and a certain kind of pragmatism. One of our specialties here at Pine Street is our research into comparing all those things and studying all those things for interactions so that we can assure somebody that the entire package that they're doing has a high safety profile to it. The way we define complementary here at Pine Street is it involves the concept of what the hierarchy is. And since our practice here is sort of hierarchically designed, then if a person has an oncologist as their lead physician, then everything that we do falls in line behind that person, and that becomes complementary. So any choices that we make sure that that's properly integrated to what the lead program is. And so there's nothing at cross purposes, there's no cross-pharmaceutical problems. The expression, all the oars are in the water at the same time, everything's working. There's a whole organizing system for which we then kind of work ourselves through to arrive at the herbs that we want. So the organizing system is the age and gender and staging of that individual, and the specific Western medicine that they're going to be getting, the specific chemotherapy, radiation or surgery. Then we break our herbs into our categories of intention. Do we want herbs that are potentiating chemotherapy, those that are going to potentiate the benefits of chemotherapy? Do we want herbs that have an immunotherapy value? Do we want herbs that have an anti-androgenic value? Or herbs that are just going to deal with side effects? We're very concerned about weight loss in somebody with lung cancer, and we want to make sure that the person's calories and diet are optimal. So an entire nutritional review, making sure that the calories going in. Acupuncture is used, and it's got different uses at different parts of, let's say, a 21-day chemotherapy program.
Let's see, my white counts are within range, my red counts are just under range, which is always where they are because I've always been slightly anemic, and so that's standard for me, even though they're out of range here. And my platelets are right in the middle of the range. And those are the three principal things we look at to make sure my blood counts are right.
This is like the 7th month already.
Yeah, this is the second CT scan.
What kind of side effects do you have on that?
Almost none, and my energy has been good. I've been playing a lot of tennis. I feel good.
The scan that you had,
yeah,
is stable.
Everything is stable.
Everything is stable. So there's nothing new. The lesions that were noted prior are all stable. They're not growing, and that's all a good sign.
Yeah, because that's what we want.
Right.
No change is good.
Right. Exactly. Exactly. So we just keep pushing on forward.
Good.
So
That's good news.
I'm encouraged.
I am too. I'm very happy about that. What I have now is I have a disease which is stable. I'm not in remission, I'm not cured, but it's stable. We're treating my cancer as a chronic disease. That's the new way to look at it, if one is lucky enough to be in the stage that I am. And clearly, though, there's something very different about me, because all of the statistics, all of the history shows that someone that had stage 4 lung cancer like I did 5 years ago would have died in 8 to 10 months. But I didn't. Yes, it's due to my positive attitude, my hard work, my support group, my doctors, the new medicines, but it's also due to something that's different in my body, in my chemistry, that allowed my body to respond to these medicines. In a few years' time, maybe they'll be able to do a bunch of tests on me or someone like me and say, aha, you have stage 4 lung cancer, but you're a particular case, you have a particular kind of chemistry, you have a particular genome, and therefore we can treat you with targeted therapies that go for the mechanisms that have gone astray in your body.
I think we're making significant progress. If you look at the big picture, that is cancer treatment over the last 50 years, there has been over a doubling of overall survival in cancer as a whole. I mean, that's a pretty impressive achievement for 50 years, which is a relatively short span in the overall history of the human race. At the rate we're going with the technology that we're developing and the tools that we have available, this pace is going to accelerate. And my prediction would be that we're going to see another major increment in our ability to prevent cancer, to diagnose it at the stages that are very early so that it's curable, and in those patients who eventually develop cancer, we'll have ways of treating it that are much less toxic and have much fewer side effects than the current treatments that we have. And I would anticipate we're going to be seeing these advances within the next 10 years, if not even sooner.
I'm Farooq Kambata. I've known Wells about a good portion of 30 years, 28 to be exact. And one of the things that has come through loud and clear to me is just the amount of progress that one can make through willpower. When you know of somebody live who's done that, then it kind of it hits home. You know, it's like there's a living example of a person who has beaten the odds, so to speak, and someone like Wells has actually demonstrated that if you really make the necessary changes and you focus on the problem and you approach it systematically and you are determined to fight, you actually can lick the problem, and he has done so and shown it in spades. So my message to whoever it is that, hey, don't succumb to it. Yeah, talk to your doctors and take your medication and do all you can. But if you have a positive frame of mind, it is an incredibly important ingredient in the total scheme of things.
Well, that's my story. I'm a 5-year survivor of lung cancer, and I will probably live with this disease for the rest of my life. But it's going to be a full and very enjoyable life. I don't want to think of myself as a rare exception, but as someone who has been very lucky and has worked hard at the disease. Progress is being made every day, and even the experimental drug that I've been on was just approved by the FDA. So I hope that this story has helped you and will help you to live your life with cancer in a full and enjoyable way as well.
Now 8 years old with a flour sack cape tied all around his neck. He climbed up on the garage, he's figuring what the heck. Screwed his courage up so tight that the whole thing come unwound. He got a running start and bless his heart, he headed for the ground. Well, he's one of those who knows that life is just a leap of faith. Spread your arms and hold your breath and always trust your cape.